Hey, what's up guys? I wanted to do a quick clinical reasoning video on a sort of patient case study I had. This was a 60-year-old chap. His social history is that he's basically in a very manual, labour-intensive job. So he's actually up on his feet a lot of the day, and he came to me essentially complaining of unilateral leg pain, some symptoms, sort of neurogenic symptoms referring into the anterolateral thigh for the most part. Also some lower back pain as well, and these symptoms were particularly more prevalent when he was actually up on his feet, standing and walking. He had relief in sort of stoop standing, and this presentation for me, and I remember going over this on my outpatient kind of placement when I was a student about, so like typical discogenic back pain is very much flexion intolerant, so people classically will feel much worse, kind of slouching, stooping forward, sitting, that kind of stuff, and have relief when they get up and move and walk and in a more extended postures. Whereas stenosis is quite the opposite in that it's more of a classically extension intolerant pattern, where a little bit of flexion, so if you think about people on their bike, sort of with that little bit of leaning forwards, or equally if they're sort of pushing around a trolley in the supermarket, will feel relief, or indeed symptoms will be worse when they're up and walking about. When they sit down and even slouch, they tend to feel better. So that immediately, and also given his age, this is a condition more prevalent in the older population. That's probably due to the fact that you're going to be more likely to get occlusion or impingement of nerves due to arthritic changes, bone spurs, osteophyte formation, ligament hypertrophy, causing that kind of nerve compression from when they exit out of those foramen. That's essentially sort of the way I explain to patients. If you imagine, like, here's the sort of port or the hole where your nerves run through, and the more you're kind of backward bending, the more upright you are, you start to get that space closing off. When you lean forward, that space opens up, and that's why you feel that relief. There is a clinical prediction rule, I think, by Cook. Did I write that down here? I'm sure I did. So this is from Cook 2010, clinical prediction rule. So it's 5 points. It's a 5-point sort of list of criteria to ascertain what the diagnostic likelihood is of somebody having this condition. They are bilateral symptoms, which he did not have, leg pain greater than back pain, which he did have, AGS, walking and standing, which he did have, eases sitting inflection, he also had, and then age greater than 48, which he also had. And if you get 4 out of 5 of those being positive, which he did, you've got 98% specificity. So a pretty solid number to hang your diagnostic hat on, so to speak. Anyway, so pretty much convinced with the diagnosis there. And so the treatment we went through was essentially based around a centerpiece of flexion-based exercises, sort of child's pose type position, knees to chest, posterior pelvic tilting, in crooked lying, and some activity modification to limit prolonged periods where he's in extended posture or extension-based activities. Now, he'd come to me after a while of having had this, and now actually flexion was becoming sore as well. And this is where I think it can get a little bit confusing, because he's thinking, oh, hang about, I thought that was supposed to make him feel better, but now that's also painful. So if you think of it this way, in the in the short term, people will resort to flexing forwards to to alleviate symptoms. But if you're doing that in the long term, you're pretty much just spending prolonged periods in stoop standing. As soon as you bend forwards like this, you know you're exposing your spinal erectors, your paraspinals to a constant increase in stress. That means to be contracted isometrically for prolonged periods. They go into fatigue out. Imagine just being permanently in like a Romanian deadlift position, and you'll know the feeling that's going to manifest sooner or later. The other thing is that you're also, if you think about it, constantly in a bit of hip flexion as well. And one of the other kind of factors that can then become an issue is that you develop a lot of hip flexor overactivity, short through the hip flexors, so that then when somebody tries to extend again, they find it difficult. Maybe they can't even fully extend, but they start to anteriorly tilt to slack the hip flexors off. Their lumbar goes into some hyperextension and the symptoms feel worse. They tend to, and this chap did have limited hip extension, and actually when I was doing a femoral nerve stretch test, which was positive, he also couldn't go that far into hip extension before his pelvis anteriorly tilted, then he got his back pain again. So I think there's a justification there for working also on mitigating those effects, working on lumbar paraspinals, soft tissue work, hip flexors, lengthening techniques to reduce any excessive tone to those muscles, so somebody can resume extension without hyperextending, and also if you think about it, like in gait, when they are walking, they try to extend their hip. If they lack that range of motion, they will again hyperextend and keep exacerbating their symptoms. So anyway, that's just I intended it to be a quick reflection, but hopefully my musings on that have helped you out if you happen to get any cases like this in future.